Good evening, friends and colleagues, and a warm welcome to 53rd edition of the 4D session, which entails a detailed discussion on the intricacies of diabetes. Tonight, we'll discuss on challenges in the primary care for diabetes and hypertension, and we know that hypertension is known as a silent killer. We know it affects the five organs, namely the brain, retina, heart, kidney, and peripheral vessels. And because it affects these vessels, it can cause a sudden death or a death which is inevitable. So, therefore, it is called as a silent killer. Now, we know the prevalence of diabetes and hypertension together is quite common. If you see patients with diabetes, 50% of them will have hypertension, and if we look at the patient of hypertension, 40%, close to 40% of them can have diabetes. So that's very close association because they share many common risk factors. Therefore, this is a very close association, and therefore, treatment of hypertension is equally important, perhaps more important than treatment of blood sugar. That does not mean you underestimate blood sugar, but treatment of hypertension is of immense importance when you take a patient of diabetes in a day-to-day management. Now, in the year 2023, in the month of June this year, we had the latest guidelines of hypertension, which are released by European Society of Hypertension, and this definitely emphasizes the management of comorbid condition in patients of hypertension, and of course, diabetes is one of the important. And to name few, the sleep apnea, the obesity, COPD, migraine, chronic inflammatory disease are many of these factors which are supposed to be important comorbid conditions in patients of treatment of diabetes. Now, to dive deep into this subject, today we have a very brilliant speaker, Dr. Parag Shah. And just to introduce him briefly, he is DM DNB Endocrinology from the SGPGI Lucknow. He's director of Gujarat Endocrine Center, Ahmedabad, and awarded the most inspiring endocrinologist of India by the Economic Times of India. Has done more than 50 publications to his credit, and today he will discuss in a great details about the hypertension and diabetes and how do we approach these patients of hypertension and diabetes. Over to you, sir. The floor is yours.
Thank you, sir, for your kind introduction. It's always a privilege and pleasure to share a dais with you, sir. That diabetes and hypertension coexist quite a good number of the populations, and prevalence of both are increasing rapidly. And we are seeing younger and younger people suffering from diabetes as well as the hypertension. And unfortunately, the morbidity and mortality associated either with the diabetes or with the hypertension, and more commonly because of the both, is occurring at a younger and younger age. So there are lots of huge population who is present in our society. Many of them are taking treatment properly, many of them are not aware about the disease, many of them are not able to accept the fact that they are suffering from the chronic disease like a hypertension or a type 2 diabetics. Many of them fails to fails to accept that they required a lifelong lifestyle modifications, medications, supervision by the doctors as well as from the pathology, and keep their metabolic health in a proper shape. So there are huge challenges in our country, which we all know is a vast country with lots of different type of the populations with a different mindset. It is not just the socio-economical differences or a cultural differences, but there are lots of psychological differences about the chronic diseases. Lots of people have a fear of taking the medications. Specifically, if we talk about the allopathic medications, they consider it that this is habit forming, this might create some problems for me because of the medications, my kidney or my heart can get affected. So there are huge number of challenges. So we'll go one by one, and what are the real challenges in a specifically in a primary care settings. We all sitting at a tertiary or a secondary care centers, we might have a less challenges, but we'll focus, as the title suggests, what are the challenges which primary care doctors or a primary care level physicians or a patient population faces when we talk about the management of diabetes and hypertension. Next, please. Diabetic prevalence is very rapidly increasing in our country. 1 in 11 adult populations are having diabetes in our country. Almost half of them are not knowing that they are having diabetes, or they may consider that, oh, I had a stress and that's why my sugar was little bit high. I had a COVID 3 years back, that's why my sugar was high. So that are not diagnosed, or they're not really accepted that they are having a type 2 diabetics, and they require a proper management. Proper management may not always means that taking the medications, but lifestyle measure also they have to follow. And we are only second to the China as far as the diabetic population is concerned. We are likely to surpass China as we are surpassing the overall population in the near future. 40 million adults in India have a impaired glucose tolerance, or what we call now is the pre-diabetic, who have a high chance of development of the type 2 diabetes if their lifestyle is not modified to the optimum level. So there is a huge burden of diabetes. There is a bigger problem of a undiagnosed diabetes, and there is a huge challenge that all these pre-diabetics, quite a good number of them, 30 to 40% of them in next 5 to 10 years is likely to develop type 2 diabetes unless their lifestyle is modified quite significantly. So the rise in the number of diabetic populations because of our genetic factors, which was there for centuries together, but there is a sudden change in our lifestyle, sudden improvement in our socio-economical status. We all have become practically sedentary for our day-to-day physical activity. Forget about the physical exercise. We have become sedentary. Schools are having a less time devoted to the sports. Many schools don't have a playgrounds because of the time constraints. Most of the school going children, they don't ride a bicycle. They go by either a van or a auto or a school bus. Canteen foods are commonly consumed. With these food delivery apps being available even at the day of exam, young people can have the pleasure of having a outside food delivered at home even at a midnight at 2 o'clock or 3 o'clock when they feel hungry while they are reading. So all these factors together has suddenly increased the population of the type 2 diabetes in our country. Then ultimately that leads to more than 7,705, almost 750,000 deaths caused by diabetes in our country in the couple of years back. So there is a huge mortality as well as the morbidity associated with the diabetes. Next, please. So if you take the similar scenario for the hypertension, as Dr. Nagulkar has mentioned, hypertension can lead to the atherosclerotic cardiovascular disease, LV dysfunction, kidney alternations, vision loss, severe stroke, and there are lots of causative factors which are common among the diabetic as well as the hypertension population. As you age, you are likely to get hypertension. Not so correlation with the age and the risk of development of diabetes. Excess alcohol consumption, central obesity, stress, sedentary lifestyle, salt intake, inactivity, poor dietary habits, increase into the BMR, all this together has a significantly increase in the number of hypertensive population in our country. One third of the urban adult populations are suffering from diabetes. One fourth of the rural populations also is suffering from the hypertension. You can see that all these packet foods are available, which cost 5 to 10 rupees, is available to you. Who can corner of the country, wherever you go, you will find a pack of chips or the namkeens available with us. And male, females, again, there is a huge proportion of the patients are having a hypertension in our country. So if you translate that, 29% of the patients are having population is having a hypertension. 1.5 million people are having a diabetes hypertension in the Southeast Asian populations, and 240 million people in India have will be having hypertension by 2025. So just like a diabetic, hypertension also is going to be increased by leaps and bounds. What are the challenges in the primary care of diabetes and hypertension? In spite of excellent medications available for type 2 diabetes as well as hypertension management, why we are facing a challenges? First is the lack of general awareness about diabetes, hypertension, and its related complications. For example, hypertension. Unfortunately, people consider that hypertension would occur whenever I have a stress. So, patient comes to us in a OPD. We measure the blood pressure, and blood pressure is a 180 and 110. They consider that, no, no, sir, I don't have a hypertension. Only when I came to you, I have hypertension. Ambulatory blood pressure monitoring is the solution, but practically in a real life scenario, we cannot offer that ABPM to 99.999% of the population. So acceptance about the disease is a big challenge, and then general awareness about the complications of the diabetes and hypertension and dyslipidemia for that matter. All these three are silent unless it affects the major organ by more than 80 to 90% of the organ is damaged. Patients don't have symptoms. If the cough cold increases, if the headache increases, people feel that okay, I need to take a medications, but blood sugar increases, blood pressure increases, lipid increase deteriorates. Patients don't have symptoms. So unless they are aware that it is a silent disease, as Dr. Vijay sir has highlighted, unless people accept that this is the silent killer and patients may not have the symptoms, they are not going to be compliant with the medications, consultation, and investigations. In a remote area, again, challenge about the healthcare professionals available with their qualified doctors available there. Many of the times, healthcare providers, they bow down to the patient's wish and the desires. They patients say, let me come after 1 month, let me control my lifestyle better, and then my diabetes and blood pressure would be controlled, and then I will take medication. So there's a, again, huge challenge about remote areas, trying to convince the patients to take the medications, huge OPD, less time for each patients, where a primary care physician has to see lots of patients with a lots of other ailments also. We as a super specialist, okay, we are focusing on our core strength of say diabetes hypertension management. There is a economical disparity between urban and the rural settings. Though Indian drugs are quite effective and quite cheap, but still some patients may not afford the best possible treatment. And as I mentioned, there is a scarcity of the qualified healthcare personnel, specifically into the periphery. We don't have a good paramedical staffs even in the major metro cities or a tier 1 or tier 2 cities also, who can spend some time and explain the patient, like healthcare nursing staff or a educator who can spend some time and make them understand that okay, why this diabetes and hypertension requires a regular treatment and a regular follow-up with a doctor and a laboratory tests. Financial constraints, social barriers. In our country, people consider that other than allopathy, medications have no side effects, and they try to control their disease with the pathis without even trying to see the effects, whether it is getting their disease under control or not. So all this together leads to inadequate control and a poor adherence to the medications. So that is a unfortunate challenge, predominantly in the primary care settings when we talk about the chronic disease like diabetes and hypertension. Next, please. As I mentioned, because of the lack of time, paramedical staff to support, there is a lack of communication between primary healthcare workers and the patients, lack of resources such as steady supply of the medications, laboratory supplies, free like government hospitals should have a at least creatinine lipids examination to be done, inadequate information system that does not facilitate follow-up and the revisits. Like in the example in the USA, if there is a time for refill of your medications, the reminder goes. Here, there is no system that patients would be reminded to take the medications and to go for the regular checkup. Poor support for the self-management. uh, People go by the Google, go by the YouTube videos, WhatsApp University, and they consider that now cholesterol is not considered to be important by the so and so organizations from the US, and people stop taking the statin, for example. Doctor center care process that implement the adequate counsel. So there is a huge need of the good counselors available at a private as well as the public healthcare facilities. Next, please. So any chronic disease like a diabetes, hypertension, or a dyslipidemia or obesity, most important is the healthy lifestyle, and being a physically active is the most important. I always tell my patients that everyone should walk. Those who have a legs, God has given us a leg, or nature has given us the legs to walk. No animal, no insects uses any vehicles for travel. They all use their own uh, limbs to travel from one place to another place. So I always tell that everybody should walk. You need only three things to walk. One is the legs, second is the land, and third is the desire. So two things are given by the nature or a god. The determination or a desire to walk should come from within. So we should try to explain to the patients that minimum 150 minutes of the moderate intensity simple exercise like a walking each week, or 75 minutes of a vigorous intensity exercise each week is crucial. People out of enthusiasm goes to the gym for 1 month, 2 months, and then they stop doing everything together. And that's why you have a very attractive scheme for the yearly membership, because they know that 90% are not going to come more than 3 months after they take the 1 year membership, because the motivation does not last for a long period of time. So we have to encourage people that just do a simple brisk walking for 150 minutes in a week. So if suppose somebody takes 5 days a week, only half a minute, that is hardly 5% of our time of the day. I always said that devote at least 5% of the time of the day for your health and for your well-being. We devote so much of time for our routine activity to earn money. If the homemaker is there to cook, to take care of the family, but we don't take 5% out of our 24 hours for our physical activity. Moderate exercise should include like brisk walking and the swimming. People should also consider doing the muscle strengthening exercise, but it is should be on a long term regular basis, rather than it comes out of the sudden uh, enthusiasm and then some reasons not to exercise, and then there is a huge period where people are not doing any physical activity. Maintain a healthy weight, that is very crucial. Like when I was studying in my medical college days in 80s, one of our senior teacher used to tell at that point of time, where probably metabolic syndrome and the central obesity importance was not that much in the medical literature. He used to tell that jitni badi kamar utni kam umar, means ki central obesity would lead to the less life expectancy. I remember during my MBBS days in the clinics, that teacher used to tell that jitni badi kamar utni kam umar. So that is true actually. That central obesity, now we'll know that it's the culprit of all the metabolic disorders like diabetic, hypertension, dyslipidemia, atherosclerosis, and so on and so forth. So even if somebody who is obese loses 3 to 5% of their body weight, it would improve their chronic disease like hypertension and the diabetes. So many times people are obese by 20%, 25%, and 5% weight loss sometimes cosmetically may not be very encouraging for them. Then people get frustrated that I have done diet, exercise, and I lost only 3 kg of weight. I was 90 kg, now I am 86 kg. So I lost only 4 kg of the weight, and they feel dismotivated. And that is the actually the problem, that people have a motivation, but they have a undesirable or a unrealistic expectations about their weight loss. It is possible, but more than 10% weight loss is really very difficult, but up to 5% weight loss is easily achievable. And medically 5% weight loss is considered to be medically beneficial, and that's why any obesity medications would get approval in the USA if you show the 5% weight loss without any significant side effect, that the drug would be approved for the weight loss purpose. So 5% weight loss cosmetically may not be very appealing or encouraging, but we should tell the patient that whatever weight loss you have gained, you have done, is good for your health, and try to maintain whatever you have lost. Even if you cannot lose further, at least try to maintain at least 5% of your body weight, and try to go gradually. The results would be less dramatic after you lose 5% of the weight. People will say that I was doing the same diet, exercise, and I lost around 3 kg in 3 months. Now next 3 months I have done the same diet, same exercise, same lifestyle, I lost only 1 kg of weight. So that is a human tendency, body's own tendency, that body does not allow more than 5% weight loss to be done very easily. More than 10% is really difficult. So patient get should not get dismotivated. That is what we should try to emphasize, that any weight loss is good, if you can achieve 5% weight loss, that is medically, metabolically quite helpful. Cosmetically, you may still look obese or overweight, but medically you have benefited. Next, please. For healthy diet, I think younger generation specifically are not eating a, a regular uh, amount of the fresh fruits and the vegetables, which contains a lots of vitamins, minerals, and the fibers. So we should encourage right from the early childhood to have a fresh vegetables and the fresh fruits, not the fruit juices, fresh vegetables and the juices are fresh fruits. Focus on the high fiber foods, including whole grains, limiting added salt and the sugar. Avoid all the packet foods which contains lots of salt and the preservatives, which is medically and metabolically unhealthy. Avoid limit the unhealthy fats in any form, specifically trans fats. We say to take zero. Minimize the animal fats. People may consider that guy's ghee is very good, so I only eat the guy's ghee. But animal foods in excess is again not good. Tobacco usage in any form is very detrimental to the metabolic health and the vascular health of the people. So tobacco, either smoking or a chewing tobacco, causes blood vessels to constrict, leads to the more atherosclerosis, leads to temporary increase into the blood pressure, and there will be a plaque formations within the artery, which ultimately may lead to the stroke or the acute myocardial infarctions. And it increase the risk of type 2 diabetes, the heart problem, kidney problem, retinopathy problem, peripheral vascular disease problem. Chances of diabetic foot amputations, leg amputations are very high. Those who have a diabetic peripheral neuropathy also get worsens if the patient is a regular tobacco user. Next, please. So, what are the treatment strategy for the diabetic patient? We are talking not about the tertiary care or a secondary care. What minimum we can offer, even at a primary care level, is to give the combination therapy early in a type 2 diabetic management. It is always difficult to increase the number of pill on a subsequent follow-up. So, if you know that one drug is not going to work, which is true actually in 90% of the patients, that one drug, even at the diagnosis, is not going to work for a long period of time. So, you start with the early combination therapy, takes care of the multiple pathophysiology, and which is available as a single pill, not very expensive in our country. And novel drugs like DP4 inhibitors and metformin combination, we all are using quite commonly. And now we got SGLT2 inhibitors also available with us. GLP-1 receptor agonists are good, but primary care setting it is extremely difficult to initiate GLP-1 receptor agonists because of the cost and the lots of side effects of the upper GI side effects. So primary care physicians, I think, can safely use DP4 inhibitor and SGLT2 inhibitors, which acts through the different pathophysiological pathway, which does not lead to hypoglycemia, which does not lead to weight gain. SGLT2 inhibitor, we all know that it leads to the weight loss. When we combine DP4 inhibitor, metformin, and a SGLT2 inhibitor in a single pill or given separately, it significantly reduces the HbA1c, puts beta cell at rest, reduces insulin resistance because of the reduction into the central obesity, reduction into the glucotoxicity. So it is a safe approach that SGLT2 inhibitor, DP4 inhibitor, along with the metformin and a lifestyle modification should be started early in a journey of a type 2 diabetic management.
For a
Yeah.
wonderful lecture. I like your analogy in saying that animals don't need vehicles to walk, but men require vehicles to walk because they don't have desire to walk. There's enough land for the people to walk, and they have limbs to walk. That was a very fantastic analogy. I think I liked it very much. So after
Thank you,
wonderful
sir.
talk, there are many questions. I think we'll answer them one by one. The first question that is to you is to see that there is a lot of malnutrition in the country, and despite of malnutrition, we see higher prevalence of hypertension and diabetes. How do you explain this paradox? That one hand you have malnutrition, the other hand there's increased prevalence of hypertension and diabetes. How do you explain that?
Yeah, actually, malnutrition per se would have be in a different way. Like malnutrition is a total calorie starvation, protein malnutrition. But in general, like somebody who is not very affording, who is not able to have the adequate amount of the food, and he is a generally malnourished, like macro as well as the macronutrients are deficient. In them prevalence is definitely less compared to the those who are having a good socio-economical status, but it still can occur. because unfortunately genetically we all are what we call the thin fat Indians. So even though somebody does not look obese or overweight, has a some amount of insulin resistance, and if somebody has a bad genes and there is a sudden change in their lifestyle, the chances of them also getting a diabetes and hypertension is high. It is still less than those who have a good socio-economical status and they have a overnutrition is there. But in general, they have a less chance, but still they can develop hypertension as well as the diabetes. So nobody is immune to not having the diabetes or hypertension or even
Yeah,
dyslipidemia. Many times people feel that I am thin and lean. How can my lipids be so high? And we see lots of patients who are BMI is 18 or 19 and their LDL is 180, 190. And sometimes people are wondering. So all these are a metabolic problem which gets aggravated from the bad lifestyle.
yeah, I think you're right because we had this ICMR data, which was published on the 6th of June 2023. And what it said that we surveyed almost 28 states and 8 union territories, covering almost 113,000 population. And what was seen that the incidence of diabetes was 11.4%, hypertension was 36%, and a central obesity was 40%, and dyslipidemia, as you mentioned rightly, 81%. So this is the population that we have, which is strongly atherogenic and has a central obesity, which is a basic cause for all these metabolic conditions like dyslipidemia, hypertension, obesity, microalbuminuria, and so on and so forth. Plus, we have the aging population because of the longevity of survival
Longevity.
and the rapid urbanization of the rural areas also now because most of these facilities are available even in rural areas. And as you already mentioned about decreased physical activity and highly processed food which people eat, because Dr. Mishra has presented a paper in which looked at people in Delhi. They're eating absolutely food on the street, which just cost them 10 rupees. And this food is very concentrated in saturated fatty acids, and it is a very cheap kind of food, but it is a very unhealthy food. And because of these reasons, as you also mentioned about Asian Indian phenotype, we have the high prevalence of hypertension and diabetes in our country. Okay, let's look at the westernization of the Indian population. Has it any contribution for the hypertension in India?
Yes, I think see food industry has significantly increased. It is easier to get food packet than to get the medications or even a bottle of water. So any you can corner 5 rupees food, a people with a Mercedes or a people on a pulling a cart would afford. So all this processed food, which is very palatable, not perishable, easy to carry, you really enjoy the taste, and lifestyle has suddenly become very sedentary with this internet. I think most of the people their free time they spend on the mobiles or an internet rather than going for a walk. People will say that I don't have a time, but they will spend half an hour or 1 hour or 2 hours on the screen time. Screen time is increasing, and everybody in this country spends at least 2 to 3 hours per day on an average on the different screens, most commonly the mobile. So we have seen the people who have totally westernized, and we have taken the bad habits from the west. We have not taken the good habits. Like in Australia, every weekend they will plan for the some sports activity or going to a beach or swimming or doing some sports activity. In India, Saturday, Sunday, gyms and the walking parks are totally empty. Sunday, practically nobody does any exercise. While we have more time, we should exercise more rather than taking a holiday off. So restaurants are all full. Food delivery apps are there. Even in the tier two, tier three cities, also all these fast food chain franchises are open. So rapid westernization, rapid marketing by this food, so-called healthy food, are not always healthy. Sometimes
Yes.
people say that okay, we only eat the this type of the food which is supposed to be very healthy. Actually, if you see the calories, practically except water, buttermilk, and a lemon juice, everything has a calorie except salad. I think on an average, every food which we consume, 100 grams gives you minimum 350 calories. So people sometimes say, I take only the boiled sprouts. but the quantity also is important apart from the quality. So this rapid westernization, all this processed food puts on lots of preservatives to keep them fresh, which all are having a high sodium content in there, and that again would increase the prevalence of hypertension. And of course, the you see all the packet food contains the palm oil because it keeps them fresh and the crispy. Apart from being a cheap, you take any packet food, it will have the palm olive, whether any biscuits or any namkins, because that keeps them fresh, crispy, gives the taste, and it is cheaper. So all this together, I think we don't know the n number of the preservatives, colors they use. So all these things together, I think, has increased not only the metabolic disorders, but significantly increased into the incidence and the prevalence of the different types of the malignancies also has increased significantly. So this
Right.
price we are paying for the rapid westernization.
Yeah, I think you're right. It's urban area, of course, there is because they have all the access to all the modern things. But what is interesting and what is worrying us, even in the tribal areas, there are studies done in the eastern part of India and Nagaland, which we know that all these tribal areas consume less salt. We heard of the Kumamoto communities or those tribal areas. The consumption of salt is very less. And that's why the incidence of hypertension is very less in tribal areas. Now, what's the state in tribal areas today? They have a very high consumption of salt, and 40% of the people in Nagaland have hypertension, which again tells you that even the tribal community also has undergone a metamorphosis, has undergone change in consumption of salt, plus tobacco is again additional factor in them, which has caused the increase in hypertension. And they also have now come under the purview of stress. They also now have a stress. We know that there's a lot of the riots in Manipur and all those areas, the tribal areas, and they also a lot of stress. So therefore, the urbanization is not the only uh, affected population, but even the tribal areas are also affected because of hypertension. That's why the incidence in India has come to 36% in the general population, which is pretty high, even above the incidence of diabetes. 11.4% is diabetes, but 36% is hypertension. That is the impact. Okay, let's move ahead. There's one more very interesting question on the hypertension and diabetes, this kind of a double trouble that we have in patients of diabetes. What is the prevalence, number one, and how can we prevent this?
I think, as you mentioned, almost half of the population who are having a diabetes have a hypertension in some stage of their life. And as
Yes,
the life expectancy increases, atherosclerosis as a part of the aging also would increase. So naturally, those who are having a long-standing diabetes, they are more likely to have the hypertension. Number two, hypertension patients, almost 40 to 45% would have a some sort of a type 2 diabetes. So the best thing about to tackle this double trouble is to have the healthy lifestyle to reduce the central obesity. At least 5% of their body weight loss is a must. Regular exercise, cut down on their outside food, take the homemade food as far as possible. Once in a month is okay. But now people say occasionally means three times, four times a week they consider as a occasional outside food. Second, people consider outside food is only when they go out to the restaurant they eat the outside food. When I ask the patient about the how frequently you take the outside food, they say once in a 2 weeks, sir. But there are all the breakfast and the snaking is all outside food. Nobody takes the home cooked food now as a breakfast or a snaking. So all this outside food is not just the going out to the restaurants. All these packet foods, all the foods which we consume at home, like all these namkins, all the things has to be cut down. Decrease the salt intake by at least 25%. Decrease the fat intake by 20%. Decrease the simple carbohydrate as far as possible, have more of a complex carbohydrate, have more of the fibers in their diet, have the healthier lifestyle, have some meditation to have the reduction into the mental stress. Being endocrinologist, I know that the stress will lead to lots of stress hormones, what we call, and that again would aggravate not only diabetes and hypertension, but will aggravate the atherosclerosis also. Have some time for the meditation and a yoga, have the healthy lifestyle, and if either of two are there, try to make sure that you are having a diabetes today, you are more likely to have the hypertension in the future. So even if you're not hypertensive now, so at least keep a check on your sugar and the blood pressure and a lipid. I think what we say, the ABC, A1C, blood pressure and the cholesterol, these three are the most important. Avoid the tobacco in any form of the tobacco. People consider tobacco only related with the cancer. I always tell that so those who I spend 5 minutes with each patient trying to make sure that they lose their habit of a tobacco, quit the tobacco. And many of the most of the people would say that what harms tobacco does, they consider that it leads only to the cancer. They don't understand that it leads to the metabolic problem, atherosclerotic problems, infarct, stroke. Also is increased significantly. I tell that unfortunately or unfortunately, cancer occur in among say 1 in 5,000 patients consuming tobacco would develop some cancer because of the tobacco. But 80 out of 100 people who take tobacco, and if they have diabetes, hypertension, they will develop a atherosclerotic disease. So we try to tell them that it is not just the cancer we are afraid of. We are afraid about your metabolic and vascular health also is important. So all this good healthy lifestyle, and now they've got an excellent medication like SGLT2 inhibitor, which helps for your metabolic health. And we got an excellent RAS blockade available with us. So we tell our patient that if you are having a diabetes, hypertension, dyslipidemia, if you are disciplined life, the medical science has evolved to an extent that we ensure you that you can have a longevity up to 85 years with a good quality of life. So I think this double trouble requires a overall lifestyle modification approach, and accept the fact that they are having a disease which requires, along with the lifestyle modification, a regular medication, regular health checkup, and regular consultation.
I think you're right. When you talk of diabetes and hypertension, there are common risk factors, namely obesity, dyslipidemia, insulin resistance. What Dr. DiFranzo has mentioned is the insulin resistance in the blood vessels of the muscles, which is a very important ninth component of the ominous octave, which is extended now today. And he says that this insulin resistance causes decrease in the caliber of the capillaries in the muscles, and therefore increasing the insulin resistance even the muscles also. That results into hypertension. Plus, we have the multiple genes which ultimately bring the diabetes and hypertension together, and therefore they have a common existence. Therefore 50% of diabetics have hypertension and 40% of hypertensives have diabetes. Both of them together result into atherosclerosis, as you mentioned, endothelial dysfunction, and a vascular fibrosis, vascular inflammation, and arterial remodeling. And because of that, you get a microvascular and a macrovascular complication. And that's how the diabetes and hypertension makes a double trouble, and therefore has all possible complications to the patients of diabetes. I think we have another 5 to 6 minutes for the last two questions. And the one of the important questions there is a rural and urban divide. It is said in the rural population there's more of a diabetes, whereas urban population is more of a hypertension. This is what is the survey which is found out. Then how do you explain the association of a higher incidence of diabetes in the rural population and a high incidence of hypertension in the urban population? How do you explain that?
I think hypertension is uh, more commonly linked with the amount of stress compared to the diabetes risk, because hypertension and the stress has a very stronger correlations compared to diabetes and stress. Both has a correlations, but because of the stress, all these catecholamines would be increased. It will not be like in a very high pharmacological or supraphysiological levels, but it will be on the higher side, leading to the hypertension. So we know the life of a urban person versus the rural persons, time
Mm.
bound jobs, commitments, traffic problems, stress of the job or a study, all these together would have a urban population having a more hypertension. Diabetic in a rural population again is probably increasing rapidly because of the now the awareness about the diabetes and among the primary healthcare physicians. So lots of diabetes is picked up also early in the rural area. Previously, it was considered to be Raj Rog, present only in the affluent class, and now everybody knows that no, everybody has a tendency to have develop diabetes. So people are probably in the rural areas also are checking more for the diabetes also. And I think in a near future, the urban rural divide is going to be blurred, and it will be almost similar, if not significantly difference, because most of the farmers also don't actually do a physical activity. They do the all the farmings with the all the modern equipments. So gradually, sedentary life is penetrating to the rural populations also. So gradually, in the next couple of decades, I think there will be hardly any difference between urban and the rural populations.
I think you're right. There's a good study called Lassie study, which looked at longitudinal aging study of India, which looked at 52,000 patients in India and was trying to find out the prevalence of hypertension and diabetes. And in the rural areas, it is the more of the poverty and the eating the processed food and therefore cheap food, and that's why the incidence of diabetes is pretty high in the elderly, in the population, actually elderly in the urban area. The stress, the education, the lack of physical activity, and little more of affluence has probably brought more hypertension in the urban areas. Okay, then we'll come to the important question between the sex differentiation. We feel that the hypertension is much more common in the female sex compared to male sex. If you see number of patients of hypertension, the females are definitely outnumber the male patients. How do you explain this disparity between male and female so far as the incidence of blood pressure is concerned?
Not a very good scientific reason to explain from pathophysiological point of view that why females would have a more hypertension compared to the males, because the amount of stress to the male versus female, naturally male would have a more proportion of the males would having a more stress, though now the working class females are increasing significantly. Sedentary life, I think, is one of the common more common among the females. Now household world is available, all the equipments are available, so female are busy in their homemaking, and many of them are doing a job as well as they're to look after the small kids, so they don't have a time to do a exercise. The food also is available to the female uh, uh, at their discretions compared to the working males or working females. So that might be one of the reasons, apart from the uh, central obesity. Again, we have seen that PCOS is increasing significantly. So insulin resistance also is increasing significantly among the female at a younger age compared to the males also.
Yeah, I think you're right. Beyond the age of 30 years, there's a steep rise of blood pressure in females, and both in systolic and diastolic blood pressure. As you mentioned rightly, the PCOS, and many times the clinicians use the hormone therapy for them, and therefore they can cause hypertension. In the pregnancy, they can what is called pregnancy-induced hypertension or gestational hypertension is very common. Preeclampsia is very common. These are the forerunners of the subsequent hypertension they get. Menopause is another important cause for hypertension, and there's one specific condition called fibromuscular dysplasia, which is also predominantly common in the female sex, and therefore you find the female sex has more hypertension than the male sex. Okay, I think that comes to the last question. We saw the pandemic of COVID, and this pandemic COVID was very devastating, both in terms of financial, physical, social, and of course the medical problems to the patient. What do you feel the impact of COVID has happened in India from the hypertension, diabetes point of view? How has the
Yeah, I
COVID
think,
impacted?
see, there are two things. One thing is COVID has unmasked lots of hidden underlying pre-diabetic or a diabetic or hypertensive populations, because almost 60-70% of the population developed the COVID during first, second, or third wave together in India. So during their health checkup, the sugar and the blood pressure was checked. At least sugar was checked more frequently. Blood pressure also was checked because of lots of medication, including steroids, to be given. So you have to monitor the sugar. So lots of unmasking occurred. Number two, the lifestyle has changed significantly. Lots of people have started going. working from the home is a norm, specifically in the many fields like IT fields. Many of the remote BPOs and all now have started working from the home. So many people still are working from the home, and they have got developed a totally a different sedentary lifestyle, like late night being awake. OTT platform, for example, has significantly penetrated after the COVID. People have become more potato type of the food habits have increased. People keep on watching till 1 o'clock at night, even if they're not working till late night. So if you are awake, you feel hungry, and then you grab something. So this together, and of course, COVID, we all know, was a state of a hypercoagulability. So lots of hypercoagulability states had a impact on the vascular health of the people, and those who were underlying some metabolic disturbances, they got a more aggravated increase into the hypertension as well as the diabetes. And people consider that COVID medications would not have a very long lasting effect of like a short course of a steroids would not have a effect after 1.5 or 2 years. They are still diabetics.
Yeah, I think true, because not only during COVID, but even the post-COVID syndromes were also very important. A lot of cardiovascular, neurological, musculoskeletal manifestations were seen. A lot of people have arrhythmias because of the post-COVID state. They had hypertension, weakness, fatigue. A lot of symptoms were described in the post-COVID state, which carried on for more than 2 years. Some people had problems with COVID vaccination, especially those who had taken the RNA vaccination, also had problems of cardiovascular manifestation in COVID. Besides, COVID itself had a medical, physical, social, for example, isolation, domestic violence, all those problems were very much seen. The psychological problems were seen, and also financial constraint also brought a lot of problems to the human beings and mankind at large, and therefore brought the grinding halt to the medical management also for these patients because of lack of accessibility. They could not reach the hospital. Even the hospital would not admit such patients because they were full with COVID patients, and therefore people had a lot of sufferings because of COVID pandemic. So I think with that we complete today's discussion. It was a wonderful discussion with you, Dr. Paraksha. It was a lot of learning
Yes, sir. Yes.
experience, a lot of learning experience. I learned a lot of new things. I hope even everybody who's watching this program also had learned many things from your experience in endocrinology and hypertension. Do you want to give finally 1 minute message to the people who listen to you from the hypertension diabetes perspective? What is your carry home message? One minute carry home message.
Yeah, I think most important is to have the healthy lifestyle, to be taught right from the early childhood. We teach the small kid to brush the teeth daily, not to lie, not to steal. Okay, but we never teach them that you have to do exercise daily. So I think early, unless we embark the exercise habit right from the early childhood, it's very difficult after 30 years or 40 years of age to have the inner desire to have the healthy lifestyle. So that has to be brought right from the early childhood, and that has to come for the family. You cannot isolate one person from the family. I am diabetic, so I will eat a different food. It's not going to be happen. So healthy lifestyle including regular exercise. Keep a watch on your waistline. I think that is very, very crucial. Weigh yourself daily. Make sure that you don't gain weight, and as soon as you gain weight, you try to restrict the further weight gain and try to lose even half a kg weight gain. You become alert. Otherwise, you keep on adding this weight to your body, specifically central part. Third, accept the fact that diabetic and hypertension are a metabolic problems. They are going to be remain silent. You will not have any symptoms, but it will lead to lots of morbidity, macrovascular complications, and early mortality. Accept the disease, take the proper advice, don't stop medications unless advised by the doctor. I always tell to my patient that we don't repair the 1000 rupees mixie of our own looking at a YouTube video. Okay, our body is a wonderful body which cost you cannot imagine the cost of our body. So why we want to repair our body by going to the Google and going to the YouTube? Okay, when your TV is at fault, you go to the mechanic, the proper service center, spend money. You drive a car or a bike every 3 or 6 months, you spend few thousand rupees just to make sure that car and the bike is in a proper shape. Spend some uh, money for your health, spend time for your health. That will give you a productive life, a good quality of life for at least 80 years of your age.
I think that's right. What Dr. Paraksha says is healthy lifestyle, maintain your weight, refrain from all the habits like smoking, tobacco, and alcohol, and of course physical activity is very important. Medications are there to help you. Adherence to medication is also important, and for that the education is of paramount importance. And I think all these factors, if they carry right message, I think you can control patients of hypertension, diabetes very effectively and meaningfully. With that, we conclude today's talk. Thank you very much, Dr. Paraksha, for
Thank you,
your
Dr. Sir, Vijay sir. Thank you.